also respond to mental health act assessments. And so my presentation here is hopefully a bit of a combination of experience and my own narrative as a crisis clinician, and as much as possible the knowledge that I could pull in from the evidence base and the literature. So that's where we are. This is what the presentation is going to consist of. So this is the first bit, and I suggest we kind of take a minute there and at the end of those 6 bullet points, and just have a bit of a break. We'll go through the rapid response service. We sort of what we do, why we exist. We offer care to quite a lot of children and young people in a crisis for a time limited period, which we call stabilizing intervention. I'll describe exactly what that is in detail, so you guys can sort of know exactly what we do, and there's a case example of that as well. And then the presentation is going to shift towards the question: how do we think about a mental health crisis, or how do we think about a crisis? Because we are trying to think in a way which is often different. Arguably different. I mean, the terms like thinking about it comprehensively, thinking about crisis in a very holistic way, they feel quite normal and usual and sensible. But historically, when we had crisis services in Berkshire, well, we didn't have one. This has existed since 2016. But prior to that, the crisis assessments in acute hospitals, and they were very brief. They didn't have a particular standard. They were focused risk assessments, and we weren't sure how well needs were being identified. So so that's why I think we're going to use an example to say how are we thinking about crisis now within our team, and within that example there will be some salient points about unmet needs and risk. And then we'll take a break, and then we'll go to the next bit. So the first bit is our service so far, the brief intervention model, and a multi-agency working example. So we were set up in 2016, and the purpose of our existence is to offer higher quality care to children and young people who present in a crisis. We try and identify mental health needs comprehensively, holistically, and early. And we respond early, and obviously try and stabilize things. And one of our other interventions is to try and reduce A&E presentations, try and reduce unnecessary admissions to a psychiatric hospital, and prevent any delayed discharges from an acute hospital by providing support to these young people and families in the community. One of our roles is to also teach and offer seminars, workshops, facilitate sessions with our partners, and that is acute services, acute hospitals, A&E departments, pediatrics. That's also our colleagues in the 6 local authorities, which is really challenging, but also the approved mental health professionals who do crisis mental health act assessments with us. And schools. So we try and reach out as much as possible, and try and deliver training. So I've delivered this presentation to GPs, to junior doctors, to pediatrics, to A&E, to AMPs, to our own CAM services, and to you guys today. Okay, so how have we been doing in terms of the number of crisis referrals that we get as a service in Berkshire? So these would be presentations that are coming into Royal Berkshire Hospital and Wrexham Park Hospital. If you look at the figures for the last 5 years, 2016 and 17 was when our service was like in its first year. So we don't think that the reporting might have been that robust. However, in 2017, 18 and 19, sorry, 2018, 19 and 20, those 3 years, our referrals have been around 850 on average. The timing of the COVID has been quite interesting because the lockdown happened in March 2020. So the new year is the number of referrals are measured from 1st of April to the 31st of March. It's like the financial year. So we weren't sure what was happening to the number of referrals to our service, because during lockdown, the number of referrals would be less. But during the return to school periods, like September, October, November, the number of referrals were just through the roof. So we were like, what is the year gonna look like at the end? So when the year ended in April, on the 31st of March 2021, we did have a significantly larger number of referrals. It was about 1150. So you can see that looks like it's like a raised number of referrals. So one could argue that might be associated with COVID, but we don't know. But it is something which we sort of track every year to see the number of referrals to ourselves annually. Okay, so that's our service. Now, there's something called a brief intervention. There's something called a crisis stabilization pathway. This is the work that we do on a day-to-day basis with any of the crisis referrals that we get. And I wanted to show that exactly what that looks like for all type of complex cases. Not all the boxes need to happen in a child's pathway, because our pathway is always a needs-led pathway. Whatever the needs are of a child, the response and the actions are directly linked with the needs. So what does that look like? So we have a crisis presentation in any of the acute hospitals. We do a comprehensive mental health needs assessment. So this usually can take anything between 2 or 3 hours. And apart from taking the circumstances of the presentation, we take a history of each concern since it first emerged, and when it emerged, and why it emerged at that particular time. We also take a comprehensive family history, social care history, a developmental history, health history, then preschool history, schooling history, schooling chronology, and then we also screen for neurodiversity, which is looking for learning issues, attention, movement, sensory issues, language issues, as well as social issues. We found that it is actually sometimes unbearingly problematic if we do not identify the needs as early as possible. It really costs us. Hopefully the example might highlight that. Costs not us in the sense it costs the family actually the most. It costs the young person the most, and we're the ones who are actually seeing it often, and it's quite unfortunate. So that's why the assessment has to be comprehensive. That's why our assessment template is massive. That's why it can take about 2 or 3 hours to gather all this information, and then it can take another 2 hours to write it up and then send it to the GP and to professionals. But at the end of that information gathering, without jumping to any decisions about what we're going to do, I'm not interested in doing stuff at that point. We're sitting with the young person and the family, and we're not thinking about what needs to happen, because the first step is to make sense of what is going on with this kid, why they are here, what are their needs. So we don't jump to any interventions at that point. The next step is actually what we call, the words we use is co-producing a formulation. And that means we create.
That's better, isn't it?
So it's a kind of.
It's not there.
Because there's yeah. So co-produce a formulation means we as health professionals don't assume to be the experts and impose our expert knowledge and language onto the reality of the child and the family. We do not do that, because it's harder for the family to join us in a really reciprocal, trustworthy, and genuine relationship if we do that. So what we try and do is to use the language that the young person and the family bring to create an understanding that they own as much as we support them in creating. But we don't stop there. That's not enough. So if we have a buy-in from, let's say, a young person and a parents around this understanding of the needs, sometimes that's great, but then it needs to be extended, because we have quite often in a crisis colleagues in social care, we have colleagues in education, sometimes police, sometimes youth offending services. We have various agencies that are important partners in the reality of this child. So there's often no point in having an amazing understanding, whereas the social worker who might be involved in supporting the family might not have any idea of that understanding. And they might have a pivotal role in supporting the family, just like health services and education. So this is where the multi-agency meeting takes place. And the point of the multi-agency meeting is to share the understanding, but also to gain information. And sometimes there's something that we all need to align ourselves towards a common understanding and a common goal. So goals which are common to all agencies, so that we can work together in a united way, aligned way, in a partnership for the child. So after your comprehensive assessment, there's a process called an understanding that's created, and then the next step is potentially a multi-agency meeting. Now, sometimes we don't need multi-agency meetings. Sometimes we often don't need colleagues in education or colleagues in social care who need to be involved. So it doesn't necessarily have to happen, but a lot of the time it does when it comes to complex crisis. The next step is what we do as a team. What is our stabilizing intervention? What is the bits that we do with young people and families? But as you see, that step comes after 2 or 3 really important steps: comprehensive assessment, lots of information gathering, a clear understanding first and foremost, after all the information has been gathered. If we haven't gathered all the information, we go back and we fill in the gaps. So we don't jump to decisions or actions until we've captured every single information. So it requires a lot of digging, actually. It requires a lot of detailed questioning, and it's hard to do because sometimes we're not, as human beings, we're not used to be sort of asked extremely detailed
what would
questions.
happen is you'd be, you'd know about this leading up. Wouldn't just.
Sorry, Lisa, I think you've just joined. Thank you.
Cool. So, I'll in the next slide, I'll detail exactly what a stabilizing intervention is. But then we move on to a follow-up multi-agency review of progress. So once we've met as a multi-agency meeting, at the end of that meeting, after we've agreed what each clinician and agency is going to do, then we meet again in 6 weeks' time to hold ourselves to account that things are working and heading in the right direction. And if we're all doing the right stuff, then usually it is heading in the right direction. So there's a follow-up multi-agency meeting. And then throughout this process, we're looking at who's going to be providing longer-term care. Because we're a crisis team, we offer brief stabilizing interventions. We can't offer long-term care, but obviously we often identify that a child may have pretty enduring depression or OCD or a mixture of emotional difficulties and needs ongoing care. So we're looking at where that care is going to be provided. It's often one of our specialist community teams that provide that. So what does a brief intervention looks like? So needs identification, sharing of formulation, achieving family and partner buy-in. The partners are social care, education, police, charitable organizations, youth services, to the understanding of needs. So this is getting everyone on the same page. You guys must have heard plenty of times, I've been in multi-agency meetings and everything. Social care have got a completely different expectation often from health professionals. Health professionals have a completely different expectation from social care, and the two services are kind of misaligned. Social care often asks us, why not detention, why not hospital, why not psychiatric hospital? Health services often, CAMS often say it's not appropriate for the needs and everything. So we have to address those kind of differences in a multi-agency context and get aligned towards the common needs of a child. That's a continual challenge that we have. But that needs identification, we call it an intervention because just by doing a comprehensive assessment of a child, we feel that there are plenty of opportunities within that process to be supportive, therapeutic, and containing in that process. By just the virtue of actually getting tons of information out of a child, there is a sense that that this clinician or this team is very serious about this child. They don't want to miss anything, that there is a genuine commitment, a dedication towards this young person and the family. And we do want families to leave with that type of feeling. And we hope that that is somewhat containing as the young person leaves the hospital. Another intervention is multi-agency, the processes within a multi-agency meeting, and then agreeing a united multi-agency care plan, which is an intervention. So that's a large part of our work, actually. In terms of things that we do with the young person and the family, so we offer one-to-one therapeutic support, which is somewhat we would describe integrative. So it pulls in the principles of supportive therapy, CBT, DBT, systems theory, and we support the young person in helping them manage high levels of distress, learning distress tolerance skills, learning skills of distraction. So there's tons of strategies and tools that we try and work with young people on. There's also family support and intervention, and there's also medication management, which is something where the doctors need to get involved to prescribe maybe a medication for reducing anxiety or lifting mood or reducing psychotic-like features. Medications are often, usually we initiate medication when someone is literally at the cusp of being admitted to a tier 4 unit. So that means when things are really, really challenging. So that's what we do. But if we open up a multi-agency care plan in more detail, this is an example for one young person that we had a couple of years ago. We got involved in assessment. The young person presented in a crisis. It was a very typical picture, history of low mood, perceptual difficulties, which are kind of like voices, but lots of homicidal thoughts as well. School were very concerned. He was a young person with autism, presenting with a depressive-like picture, and parents were just unable to cope. But because of he carried a knife in school once, so because of the risk of these homicidal thoughts and carrying a knife and etc., there was a really important need for everyone to get together. We had a massive multi-agency meeting. We had a mental health provision, but we also had education who were doing a lot. We also had social care that were doing a lot. We also had police that offered psychoeducation, and we also had the counterterrorism unit in Victoria that were also involved. So we had 12 or 13 people in a multi-agency meeting, and I think we were all aligned, and we saw we saw good results in the end. So I'm not going to list what everyone did because everyone can read that. Okay. So the next question I keep reminding myself is, how do we think about crisis? How do we think about crisis? And we'll use a case example to just show us a few simple things, well, not simple things, but just things which often might feel simple in hindsight. But as a clinician, as a frontline clinician, me and my team were going to acute hospitals and seeing people in a crisis. We're constantly faced with the challenge of risk. The word risk is really the primary word, actually. We often have parents who tell us that their child is not safe. How are you going to keep my child safe? My child is suicidal, and you're telling me that I can be discharged and I can take my child home. I don't think my child is going to be safe at home. So safety and risk is something that the services use, clinicians and services use as well. This child is at risk and everything. And it's very challenging for us as clinicians to keep responding to that, And the approach that we have is actually goes towards using language which is not overemphasizing safety and risk. We try and change the language and use more about what are the needs, are they met or unmet, and how can we meet the needs. And the needs cover everything. The needs cover education, development, mental health, family strain or family stress, drugs and substance misuse, if that is the situation, as well as risky behaviors. So so we can have a look at what this case looks like. And this is very common, actually. This is a pretty common case that we often find. So we've got a 16-year-old girl. She is got 2 older high-achieving brothers. Both parents are professionals. Arguably, many would say she's, quite. I think parents were quite affluent, living in a big house. I think both boys went to private schools. She also went to private school. In terms of her early life, there wasn't any obvious motor delay or language delay, but her parents did describe her as a jumpy and a boisterous kid, someone who was just quite fearless. Went through private primary schooling. She was below average academic attainment. She was also tested for dyslexia. The outcome was inconclusive. Parents reported long-standing social and interpersonal issues. They also indicated that there were early years of emotional and behavioral outbursts. But this girl, she did stand out in comparison to the 2 boys who were just high-flying achievers academically, also quite sporty, extracurricular, social, happy. Didn't need that level of management as this girl did. So she first presented in academic year 5 and 6. So I often go by the academic years and then say the age as well, because there's a lot of transitions that are associated in child's life academically, which are linked with periods of stress as well. So she came to, she started experiencing symptoms of emotional difficulties such as stress, anxiety, irritability around year 5 and year 6. So she would have been around 10 or 11. She then presented, she was referred, and then she presented to community camps with disordered eating and restricting her oral intake and purging. She was assessed, but these difficulties were mild to moderate, and the parents felt that they were able to manage the situation with some advice. So there's no further ongoing input from CAMS, and the case was closed. A year passed, and in 2017, unfortunately, the situation just continued. There was binge eating, purging, there was use of laxatives. In addition, there were emotional symptoms like anxiety, panic attacks, low mood. There was some support from a school counsellor, but things continued to worsen with emergent cutting, hair pulling, and there was increased irritability and then worsening outbursts at home. So things just weren't getting better. And you go with a first-line intervention like school counselling, it's emotional difficulties. Let's go with school counselling. A very natural thing to do for all of us. Unfortunately, it didn't really do anything. So in March 2017, the eating disorder concerns were just escalating. She was then seen by the eating disorders team. There was a care package that was offered, which is a combination of therapeutic support and nursing support and advice, physical health monitoring, to make sure that the child is able to eat enough and gain weight. That's the key. But in the next couple of months, the situation didn't change despite the initial input. There was severe weight loss, there was purging, there was laxative use, there was excessive exercise, and it went to such a degree that this young person collapsed and had to be admitted by ambulance to Basingstoke Hospital. She was medically treated and stabilized and then discharged back to the community eating disorders team for ongoing input. She was then, because the situation has escalated, she was then reviewed by the MDT. There was concerns about low mood, and it was thought, let's initiate some fluoxetine to lift mood. However, that didn't do anything, unfortunately, significant. There wasn't any we weren't heading in the right direction, even slowly. The risky and unpredictable behaviors just emerged and continued. So she was then absconding to school. There was suicidal threats, self-harming. She was wandering at bridges. So then from sort of middle of 2017 to February 2018, this young person was engaged with the specialist CAMS mental health team with a package of mental health provision. And this looks like weekly contacts, and that would be weekly contacts with someone from the therapies team, usually someone from the nursing or dietetics team, to keep an eye on the meal plans and eating and weight. And then, as I've already said, medical input as well, to offer any MDT reviews with the team, use medications to alleviate challenges. So she continues to receive that from the middle of September to early 2018, but her condition doesn't improve. She continues to suffer and struggling, and then it led to continued weight loss, and then she was admitted to an eating disorders bed in May 2018. So just to recap, so her journey starts in sort of, let's say, early 2016. 2017, she starts accessing services. And 2 years later, despite counseling, despite CAMS package support, despite medications, she's just continuing to worsen. And it ends up going into a tier 4 unit. So she's heading in the wrong direction despite the standard conventional CAMS interventions. Right? She's discharged after 2 or 3 months, and now she's discharged with a very comprehensive package of CAMS input. So this is individual psychology, family therapy, there's medical reviews, there is now an addition of an atypical antipsychotic called aripiprazole, and this targets things like agitation and impulsivity and reducing anxiety. But she's not shifting. Again, she's still heading in the wrong direction. Things come to a head. It was very unfortunate. The family's at home. She wanted to, I think it was some sort of social event, some sort of party that she was involved in, and it was about boundaries. Parents had to take some measures to have curfews and boundaries so that she was safe enough, because there were concerns about her absconding, running away. There were concerns about her putting herself in sort of risky positions, like getting very, very intoxicated. So the parents had to naturally put in boundaries, but she did not, obviously, not like those boundaries, and it is just, obviously, she was feeling pretty miserable anyway, and she threw some boiling water at mum in one of those interactions. So the mum suffered some significant burns. Parents had to call the police, and she was not able to return to the family home. But this is not just one episode. These are repeated episodes, tremendous amount of gradual family strain. And we often find that the parents often tell us, well, we can't cope anymore. We can't deal with this. It's too much. Please admit her, please to take that type of thing. So, yeah, so major assault, mum suffered burns, police now get involved. She can't go to the home, so she's actually removed from home. Social care get involved. And this is a period of 6 months where she is, it's really unfortunate. She was like 2 months somewhere in the south of England. 2 months she was in somewhere in sort of North London, and then 2 months or so she was in a foster home in Berkshire. But the descriptions that she gave me about the places that she had to be in, like sleeping on a sofa on a corridor in one particular place, unregistered places, etc. It was, and with adults there as well. It was. I don't know how much of that is completely accurate, but this is what she said to me, and it just wasn't nice. It was just really unfortunate to see what this kid is going through after being so unwell, and then now being kicked out of her home and then staying sort of in various places. And I was thinking, what's happening to her mental health? So anyways, she comes back to Berkshire. She's in a foster home, and there's a plan. Social care are very much involved now. There's a plan for her to reintegrate back to her family home. She's got a lovely big house. She's got 2 parents who do love her, and there's absolutely no concerns from like in terms of how reasonable and sensible parents are, and they do want to have her back. But it's so there is a plan for her to come back. But and there's another incident. Something happens which was a combination of a split with a boyfriend as well as an interaction with her parents that led to another episode of agitation, and she takes an overdose. Now she's taken a big overdose, and now she gets admitted to Royal Berkshire Hospital. She's in Royal Berkshire Hospital, and she was very, very agitated. She wanted to be discharged, and she was destroying property in the acute ward, throwing laptops, shouting, screaming. It was extremely challenging to manage her. She had a Mental Health Act assessment to decide, does she need to be admitted in a psychiatric hospital again? But she was not detainable under the Mental Health Act, and the community option was advised, and she was very keen to engage in that. So now we have a 16-year-old girl, 15-year-old girl. She is in Royal Berkshire Hospital in the acute ward. There is really a lot of agitated behaviours. Parents are like, we cannot take her home. Look at her, the way she is. She can't go to psychiatric hospital, and social care are like, well, what do we do? So social care had to go to court to make an application for a care order because they would have to place her somewhere. So the situation goes to court. The judge, oddly enough, kind of, this is a different story I'm not going to go into, but sort of very strange order. Sort of, in the end, it was an unlawful order, actually. Say that this young person to be taken to Willow House, and then also have another sort of assessment. The only way a young person can be taken to a psychiatric hospital is either through voluntary consent or under the Mental Health Act. So it was a very strange order, but in the end, the trust solicitors did advise us that that order would have been appealed, and it wasn't a lawful order because there is a very clear law as to the circumstances when a young person can be admitted to a psychiatric hospital. The law is very clear on that. So anyways, it caused a lot of confusion at BHFT. Our team, our head of service, was like, what is this? A judge ordering a young person to be admitted who's not been detainable under the Mental Health Act. What is going on here? So regardless, she was still in RBH, and our team went in and did an assessment. So the rapid response team wasn't involved actually until really that point. Until after the Mental Health Act assessment. So we get involved just to give her a fresh assessment from the outset. The key question we had was, why are things going the wrong way despite so many different interventions? Aren't kids meant to get better when we offer interventions? What else do we do? So everyone's wondering, what else do we do? Anyways, we try and just start completely afresh, take a full history from the beginning, and just run through all the possible needs for this kid. My suspicion was that something obviously might be unmet. But I mean, at this point, what we saw, the history, the narrative of this case is that we can keep throwing interventions, mental health interventions. I mean, let's start with counseling, then with eating disorders input, then psychology, family therapy, then let's do an antidepressant, then let's add an atypical antipsychotic. Okay, let's do a tier 4 admission as well, right? We keep doing stuff, right? But why isn't this kid getting better? Well, this kid is also getting riskier, not just not getting better. This kid is wandering on bridges, self-harming regularly, taking overdoses. She's not an assaultative and aggressive, violent girl, but her levels of agitation was such that she did a pretty major assault on her mum. And she gets removed from home. She's at risk of being in secure care. So at this time, in RBH, this kid was being applied for a secure care provision, right? So the risk is very, very high. The word we use is risk, which is used. I mean, you can argue the risk is very, very high. And neither is the risk met, neither is the mental well-being met. So the big question is why? Why is that? And that's where that's why we really try hard in our team to not focus on managing risk, but focus on managing needs, because unmet needs are the biggest perpetuator of mental ill health, mental distress, repeated crisis. So anyways, when we did an assessment, it wasn't just us who did the assessment. The parents always, they had a gut feeling that there was something neurodiverse about her. There was something not right about her, even when she was a child. There was something different about her, and they couldn't put a finger to it. So they sought out themselves a private assessment in Oxford, and it was a comprehensive neurodevelopmental assessment which looked at her social profile as well as her attention. They identified that she had borderline ASD. She didn't meet criteria for ASD, but she had a lot of ASD traits, and she had very clear ADHD. So there was a tremendous amount of hyperactivity and impulsivity and really poor attention. And so they gave us the report, so that informed the input of RRT. And when we then sort of took in a fresh history, I mean, we kind of changed the formulation. We kind of, first of all, sort of said, okay, first and foremost, is this girl's neurodiversity recognized? Has it been acknowledged? Has this young person been supported in acknowledging and validating the reality that she's experienced since she was 5, 6, and 7 throughout education? That's the first thing. Has her educational needs been appropriately met over the years? Because this is not, neurodiversity doesn't affect you when you're 13 or 15. Autism, ADHD, dyslexia, sensory issues, language issues, any developmental issue will contribute to stress and difficulties since preschool nurseries, as well as reception, primary school, and then secondary school. It's a cumulative effect, it builds up. And the pattern that we very commonly see is that as the young person comes to the end of primary education or a year into secondary education, there are rising levels of stress, which gradually escalate because of the repetitive nature of going to school every day and having to manage the academic demands and the social demands. So the load on the brain increases, the stress increases, and it usually presents with not just a standard, a very typical mental illness like depression or anxiety. It often presents with a mixture of symptoms like mood swings, irritability, anger, self-harm, anxiety. And this is what she looked like. She didn't present with a very typical, pervasive low mood, tiredness, loss of interest, loss of enjoyment, sleep difficulties, concentration difficulties. No, her presentation was that of stress, agitation, mood swings, up and down. And that presented at perfect time. Not perfect time in the sense that this time when the young person is coming up to the transition from primary to secondary education, adolescence and pubertal changes are also emerging at the same time. The social demands on the brain is changing at the same time, and then as we progress through education, the academic demands also increase. So everything, a perfect storm, everything coming together, and that's why we have the escalating stress. So in summary, the way we try and understood this young person, not just us, it's the parents who helped us. This is where the formulation is co-produced. We took the understanding of the parents that there is neurodiversity, there's all these things that they've just picked up. And we identified her as a young person with ASD traits, with ADHD, with mild cognitive difficulties, who has struggled throughout education as well as socially, and is now presenting escalating levels of stress. So what happens? So this is what happens when, at that point, if that understanding isn't there right in the beginning, then this is typical of what happens often. And we are talking about ourselves. We often say, let's do counseling, let's do CBT, let's do this and that. But those things don't work. Those interventions, this is an example. Tons of those interventions just did not work because we were not meeting the needs. We were not meeting the needs. So nobody had talked to her about, why do you think things are different for you? What do you think about these diagnoses, the things that have been identified with autism and ADHD? What does that mean to you? Does it make sense to you? Do you reject it? Do you accept it? So what we did was we tried to meet the needs. We instantly engaged with the family. What we started to do, we said, if you would like, we can treat ADHD. Let's start stimulants. Let's do that straight away. And you'll see us, and we'll see the response of the stimulants and see what that does to your attention and impulsivity and movement. But prior to that, the key thing that we did was sharing the formulation with the parents. We needed to be reassured that the parents, they bought this understanding fully, They needed to feel that, yeah, this is a right way to see their child. And so does this young person. She needed to feel that, yeah, this is a better way to see my difficulties, to see my reality. So we had that, luckily. The parents, from being considered to be taken to secure care, the parents actually said, okay, we'll take her home and give this a chance. So instead of, yeah, whatever, instead of that uncertainty about where this kid is going to go, we offered a very clear care plan that would meet her neurodiversity needs. And the parents took this young person home. We started ADHD treatment. At the same time, we targeted psychological support, which was more towards managing mood swings, distress, agitation, irritability, that type of program, which is more the DPT type of input. So that we added that in parallel. We added the ADHD treatment and medical reviews in there. And what do we see? Within 6 weeks, an amazing resolution from this child who was, wandering at bridges, running, absconding, not listening, family at the brink of well, they did break down actually. Family did break down. They couldn't have her back home. A young person at the brink of being taken to secure care. So when we followed her up, within 6 weeks, we're coming back. The parents are sitting here. She's having calm conversations, hardly any irritability with her parents. She's at home and she's sort of pairing socks for like 40 odd minutes, and parents are like, we've never ever seen that in our lives. She starts to wash her car and finishes it after half an hour. Parents say, we've never seen this has never happened in her life. She only starts things and 5 minutes later she's somewhere else and she doesn't usually sustain any activities. She was looking for part-time jobs. She had enrolled in education for September to start in Reading College. But the key thing was what was happening day to day. She was adhering to rules and curfews. There were better family interactions. Parents were happy. Parents were telling us we're very happy. We've seen a fantastic improvement. And you know what? I saw her for a few times, literally 2 or 3 times in the next 2 months. And then I handed her over to the community team for ongoing care. And from that point, we have not heard from this family. There's been 2018, 2019 this took place. It's been 2 years, and we've not heard from this family at all. So whatever she's doing, she's out and about in the community, just getting on with stuff. So, what is the point of that type of case example? And I can literally, off the top of my head, just talk about another case example just last month. It wasn't ADHD, it was something else, but we met her needs, and from presenting 10 times in 5 months, from August to January, this last gone, 2 acute hospitals, and being given a DBT program from an out-of-area service, still no improvement, and an acute inpatient hospital admission. Again, needs not met. She continues to remain distressed, presents in acute hospital. But it's only when the needs were fully identified and met. Again, she's sort of calm now. So these type of examples, what I'm trying to say is quite common. So a lot of the times in these meetings that we have with families and then with social care or these multi-agency meetings, everyone's focus is on risks and safety. That's what everyone's thinking about. And I don't think there's necessarily it's not I mean coming from a CAMS perspective, because the language is different in different organizations and different cultures. Language in education is different, the language in social care is different, and the language in health is different. So we have to respect the difference. That's completely fine. But what we often find very difficult is that this overemphasis in these multi-agency meetings on how are we going to keep the child safe, how are we going to keep the child safe, how are we going to manage the risk, how are we going to manage the risk. Finally, no intervention works for keeping a child safe or reducing the risk unless we meet the needs. So I often find that pointless discussion, and I try and shift the conversation towards thinking about, well, what is not going right in this child's life? What is not being met? What do we not know? What if there's a crisis, why is there a crisis? Why are things happening for this now, at this point in time? Why did it not happen 1 year ago, 2 years ago? So we've got to understand why things are happening, because there's usually often they are reversible stresses, they are unmet needs, and I'll list what they are. So the risk is never managed in my, that's the point of that case example, is that, the risk wasn't managed, risk was just escalating because we focus on the wrong things. If we focus on the needs, the risk evaporates. And we frequently get examples like that from our service. But that's just not how we're doing things. I'll share where those principles come from. So yeah, we're not interested in just doing stuff first. The first task is to identify, share understanding, formulate, make sure we identify the needs, we acknowledge and validate. That's a powerful therapeutic intervention if it's done properly. A lot of young people and parents don't know what's going on, and if they have some sort of a relatable understanding to what is going on for them, that in itself is a containing intervention. And that happens within the therapeutic assessment, not necessarily giving through medication or therapy. So,
Dr. Mehdi, sorry, I've got someone who'd like to ask you a question.
Go ahead.
Giles, would you like to ask a question? Oh. Giles, I can't hear you. You've got your hand up. Did you have a question?
Sorry, I think I put my hand up by mistake. I'm very sorry about that. Carry on.
Sorry, I do have a couple of questions.
I can lower it.
Okay.
Okay.
Before you carry on, Dr. Mehdi, there were a couple of questions that appeared in the chat earlier.
Yeah.
One which was relating to the referrals slide that you showed us earlier, and whether they were new referrals, if it included re-referrals.
They include any referral that isn't open to the rapid response team, and that would include anyone who may have been referred to rapid response in the past as well. So there is a proportion of re-referrals, and I don't have that number off the top of my head. Sorry.
No, that's helpful just to know. Thank you. I can ask the other question at the end. Thank you.
And the slides can be very well shared. That's going to be
lovely. Thank you. Yes, if you can send them over to us, that'd be great to get those out.
Yeah. So we try and shift the focus as much as we can towards unmet needs. And what is unmet needs? It's anything really. It's anything that can cause stress in a child. And a lot of the time these are reversible. But our first response is to work on reversing these perpetuating factors. Because if there is a perpetuating factor that isn't being addressed, there's no point, in our opinion, to say, okay, let's signpost you to counselling, let's signpost you to CBT, or let's refer you for medications or whatever. So, for example, what are unmet needs? So, for example, if you have a young person, we've had this, in acute hospital, who comes into hospital, sort of years of self-harming, self-cutting, came to a head for some reason, and she comes in hospital and everything, and then so she discloses to us that the reason I do this is because I've been beaten up regularly by my dad for years and years and years, and emotionally abused, and in a nutshell, right? So whilst we've got the symptoms of self-harm and mood swings and low mood, but with a predominant concerns around physical and emotional abuse within the household, what is the actual intervention? The actual intervention is it's needs-led. It is at that time to make an immediate referral for a telephone call to the duty social worker, followed by a referral with an exact description of what's happening here. Nobody is going to be thinking about, okay, for self-harm, let's refer you for counselling. That would mean that the problems in the child is self-harming and needs to go to some counselling. I think so. Absolutely no counselling. We remove the actual cause of the self-harm, which in this case it was abuse, but it could be bullying, it could be child sexual exploitation, it could be anything. So what are unmet needs? There's a massive list. There's a massive list. So all of these things are associated with raising the risk of mental ill health. All of these things. The rates of a diagnosable mental health disorder in the cohort of children and young people with autism is 70% and more. But any neurodevelopmental difficulty that is not identified and not addressed appropriately is an unmet need. Absence of appropriate educational support is an unmet need. Any family volatility, disruptive caregiving, any abuse, trauma, all of that. Threats to attachment security, bullying, substance misuse, school refusal for school attendance. We often get children and young people who are severely anxious and completely at home and unable to leave the house. Often families obviously need help and support, but I say there's no point in using medications at this time because we are still in the home environment. But if there was a gradual integration to go to school day by day and increasing that over the next few weeks, then there's a better argument for using medications. But there's no argument for using a medication if a child is completely housebound and not leaving the house, not able to leave the house at all. So the first is, is meeting the unmet need. If you're in such isolation, your mental health is not going to get settled. Sedentary lifestyle, limited physical and social activity. So we always tell young people to think about their routine to the day, the structure to the day, how active they are, what kind of physical activity they're up to or not, how much social activity they're up to or not. All these things are actual interventions for improving our emotional well-being. And untreated major mental illness is one unmet need. In that list of issues, severe depression, anxiety, OCD, anorexia, psychosis, these are enduring mental illnesses. And when we identify that, that's actually quite, in my opinion, it's quite a straightforward thing to respond to. If we rule out all sort of psychosocial adversity, environmental stresses, educational, family, social, we sort of everything is fine over there. We can't identify any stressful influence, and the child is developing an enduring mental illness like depression, which happens. It's very straightforward. It's essentially a evidence-based response to, from family support, psychology, counseling, therapy, medications if needed, family therapy. It's actually quite straightforward. But our job is to first make sure that we reverse the perpetual factors. So this is a slide that my team sort of try and continually think of and remind ourselves. So if there's unmet needs, there is stress, and when there is stress, there is self-harm. So if you want to address self-harm, if you want to respond to that question of risk and safety, how do we keep our child safe? You're telling us to leave and my child isn't safe at home, etc. We address the needs, and if we address the needs, we are addressing the issues around risk and safety and self-harm. Because the same principle applies. If we go along that, okay, let's do safety management and risk management. Let's lock away all sharps and medicines. Let's increase supervision in the family home. Let's learn various distraction techniques. Let's go for a walk. Let's pet. Let's do baths. Let's do high intensity exercise or using ice. Let's call a friend. Let's call Samaritans. There's a standard list of things that we can advise a family and a young person, and we do that every time. We give a whole document with a list of strategies and tools that are distress tolerance measures, right? But we know it's going to be useless unless we prioritize addressing the needs first. So that needs to happen as a priority and in parallel, and then we have a chance. So it always boils down to, in complex crises, multi-agency care. Multi-agency care, and this is where this pathway is very commonly that we use, and it's not something that we just developed ourselves. That's not how we work. We don't just thinking that we in Berkshire, this is how we work. The way that we work has been pulled in from various guidance documents that have been published by NHS England, by Public Health, by Royal College of Psychiatrists, by Health Education England, which outline principles about how a team should respond to children and young people with mental health crisis, in terms of how do we think about it, how do we assess, how do we respond. So we have got guidance. So what we do is we implement that guidance within our team, and that's what a lot of the time it looks like. So these are the guidance documents that, I think the really helpful document is Health Education England one, the competency framework, because it really emphasizes the importance of identifying needs, of comprehensive assessments, of good communication, good collaborative working. These principles, they are nicely outlined in these documents. Okay, so that's our service and highlighting a very important principle in our opinion around how do we approach crisis. We can move the presentation onwards to a few slides around risk, because you find that there is a huge emphasis on risk assessment, risk management, safety, and what are we doing to do those things? What are we doing? What are we doing? What are we doing? So there's actually a few slides on that, and then there's a few slides on how do we characterize crisis more. But I just want to take a minute first. If people want to take a break, or this is a time if there's any questions or thoughts or whatever that we need.
Thank you, Dr. Mehdi. There is a question in the chat, but I'm not sure if I'm reading it correctly. It's going back to the symptoms, the list of symptoms that you've had on screen. It says, aren't some of these symptoms of unmet needs rather than unmet needs? I'm not sure if that's been typed in correctly. I don't know if the person who's put that in is able just to come in and clarify. Well, I don't know if they feel comfortable enough.
Aren't some of these symptoms of unmet needs? Is there C. Johnson here? Good question. Now it feels like a good question. I just want to make sure we. I guess there's themselves. Okay. Just wondering, what are we talking about? Are we talking about this slide here?
Yes, we came up when that slide was on. Thank you.
I mean, if it is these slides, we don't. I mean, I didn't see them as symptoms, because I mean, symptom. It's health terminology. It's used in health. So a symptom to a health professional is things that a child, young person, or patient complains of. This is, like I'm depressed, I've got self-harm, I have suicidal urges, I hear voices. These would all be described as the complaints that the young person has. But this list here, I would argue these are possible underlying contributors to mental distress. So contributors, causes, associations. So they're a bit different, because the symptom might be running away or self-harm or mood swings or anxiety. This might be a repertoire of symptoms. It might be behavioral reactions, etc. But if it's that lift, I'm just going to read again. Which is 0 assessment. Screen showing symptom problem rather than unmet need. Yeah, so just to Ms. Johnson, just to respond to that. So school refusal is actually a presenting concern. It's a concern that a child is either resisting to go to school, not able to go to school, and that would be a presenting difficulty comfortably. But it in terms of after an assessment, after a period of assessment, it can easily be a perpetuating factor as well, because anxiety can never be reduced unless the young person is actually exposed to that anxiety in a very careful and a graded way as well. So anxiety will not lessen unless there is a gradual reintegration plan of exposing ourselves. So yes, it is a symptom, but it also becomes a barrier to reducing the anxiety as well sometimes. So getting to school, it's also a big challenge when children and young people don't have that routine and structure and that stimulation that is provided in the school setting. It's very difficult to expect improvements in feelings as well, because those things are a big distraction and they're a healthy distraction. So it's part of our standard action plan that we have to have a routine and structure. If we have the summer holidays, then what are we doing in the daytime? What time are we waking up? What are we doing in the morning? What are we doing for lunch? What are we doing for afternoon? What are we doing for the evening? What time are we sleeping? Because the structure is already challenged in the summer holidays. But for kids who are vulnerable, for looked after children, kids with neurodiversity, they absolutely need that that structure to keep them well. I'll just respond to Nikki as well. Is that Nikki Pritchard from RVH? I think. Is that Nikki, the other pediatrician? I'm assuming it is. Yeah, Nikki, I would argue.
Yes, it is, Ahmed. Yeah.
Nikki, absolutely, I would argue, yes, the diagnosis is less clear at a younger age, particularly in girls, and particularly in all high-functioning, developmentally high-functioning young people, boys and girls, people who have, let's say, high intelligence, great language, and who might be, let's say, quite social. If there's any neurodiversity, let's say, things like ADHD, it is harder and harder for that to be picked up early. And it's just not picked up early because you need those stressors of adolescence, such as the increased social and emotional demands, as well as the increased academic demands that gradually emerge in secondary education, or at that point of year 4, year 5, year 6, when you're preparing for the SATs and entrance exams and everything. It takes those moments in a child's sort of life history to actually bring to light that there might be an attention issue or there might be a social issue. So at what age these things are actually detected depends on various dynamic factors. I mean, we know for a fact that with girls and with autism, girls are able to mask it. There's something called camouflaging. It's not observable. They're superficially, they mimic social skills amazingly. They appear superficially sociable. They're also often academically very bright and really well behaved because they have anxiety inside. So they're perfectionist, well-behaved students. So they never come to the fore. And there's this Coke bottle effect that many specialists have described, that you have a very settled child in school and then they're coming home, and then you've got absolute high levels of tension and volatility and irritability. And then when the parents say, well, this is what we're seeing at home, schools think, oh, well, it doesn't happen in school, it's not our problem. So it is very challenging. But I mean, being a doctor, being a health professional, our philosophy is early intervention. So we, good or bad, our business is to identify these needs as early as possible. And and it's completely valid to think that, as parents, if I'm thinking as a parent, I don't want to see problems in my child. We don't want to see problems in our child, and it's hard. It's a really hard thing for parents to do as well, to see that there is something which is different. Okay, do I need to take steps? Do I need to see someone? Do I need to speak to someone? So a lot of stuff isn't is referred a lot later as well. And then the philosophy of education is also arguably different. It's highly on positivity, on everything, which is different from sort of coming from a health and a medical background. So so I don't know. I mean, I think there's a lot of factors. Ideally, I would prefer to identify needs as early as possible from the time somebody raises a concern. Working in a crisis service, we try from the point we met them. There's a standard assessment template which gathers as much information as possible, and it's the expectation of all our clinicians that we follow that template, gather that information. And if there's a gap missing, let's say developmental history is missing, we go back and say, let's fill that gap. Let's find that information. Let's rule out any sensory issues, any dyslexia, learning issues, any social issues, any ADHD issues, blah, blah, blah. So we adopt that approach, but societally it's a different thing.
Thank you, Dr. Mehdi. Rebecca's asked a really interesting question following on from that around actually what you're looking at being a trauma-informed response, which is really resonant with a lot of our organisations across Berkshire West who are really working towards a trauma-informed approach to their services.
Look, I mean, my answer would be that that's not easy at all, actually. That's not easy at all. I think what I would hope that we do, and what I would aim to, if it was me, is to be as comprehensive as possible to identify all the needs. So when we say we have to identify all the needs, we are looking at a history of bullying, history of assault, sexual assaults, history of family volatility, disrupted caregiving, history of any unintentional or intentional neglect, history of any physical abuse or any sexual anything. And we by only digging really, really deep and gathering as much information, we'll be able to kind of have a clinical opinion on the predominance of a particular challenge. So, because it's very hard on the surface to sort of say, is this ADHD or is this, because on the surface symptoms might be very, very similar. But it's when we dig through and gain and acquire detailed information from the family and sometimes collateral information from social care and education, that determination can be made. But as long as we are fully informed about the history of the child and the child's reality and the family's reality. So I don't think, I mean, I think it's, there wouldn't be, I don't think from a clinician's perspective, there would be some sort of manualized textbook way of making that determination. I think it will be a clinical opinion based on a very comprehensive and thorough assessment that, that this is an ADHD. Also, it's really important to say that if you look at neurodiversity and family adversity, the association between the two is very strong, and it's we cannot argue that it's that there is family adversity in a family because of the presence of a learning disability or other forms of neurodiversity in the family. That's necessarily it's not linear actually. So sometimes it could be the other way around, like the environmental effects on the child's brain and the maturation, etc. What kind of effects that has on a developing brain. It's very hard to know. So very good question. I think that's probably a really a specialist from sort of England or London or whatever might want to handle that. But I just thought I'd give you my thoughts at what I would do if I was in that situation. Your cohort in those overall local population. So Giles has asked the question: what do you see are any differences with your cohort and those that are in an overall local population? This is a good question. I think what our team is often handling is a lot of the time, a lot of these young people that we see are presenting due to crisis in a social adversity or an educational adversity or a combination of the two. A lot of the times, this is what we find that there's a smaller proportion of people who present to us who are just very mentally unwell, and there isn't any of those history of family adversity or social adversity or unaddressed neurodiversity or things like that. That's, in my opinion, a smaller proportion of Chilean young people. I think a majority of our presentations, the crisis is in the context of a combination of things breaking apart in the family, or some sort of bullying or social issues going on, or the demands of education contributing to the child's difficulties. So that's what we find a lot of the time. So looked after children are a significant aspect of our care and well-being. Children with autism who present with mental health difficulties or crisis, sometimes with a diagnosis of autism, sometimes with undiagnosed autism, who come to us. That's something that we see quite commonly. Okay, got questions? Yeah, I agree with Nikki's point about family trauma-related issues related to neurodiversity. Yeah. Oh God, these questions, guys. You're taking it easy on me. Other health organizations have started to introduce a CAMS trauma pathway. Look, I'm going to pass on that question because I think it's. I mean, there's no doubt that we have needs, and you know, we need more something. But the way it is, the way it's structured and you know, delivered in services, it's there's always pros and cons to the situations. With a pathway, there's always a boundary. You know, we have, for example, eating disorder pathway within this very diagnostic-led pathway. Our approach is very needs-led. We're not focused on labels, diagnosis. Our approach is whatever the needs are, that's where we go. The needs can take us anywhere. So we don't restrict. We don't have a think that this is a self-harm pathway, or this is a mood swing pathway, or you know, this is just a mental health crisis, and mental health crisis is just very loosely defined. So look, that's again a tough question. I'm not going to go into that. I'm really sorry because I'm probably not such an expert in that area as well. Yeah, I agree with Rebecca about that point. We try our hardest. I mean, we try our hardest to focus on needs. Needs is the language because it is all-encompassing. It encompasses any diagnosis of ADHD and autism or depression or psychosis or anorexia. It includes that. But a diagnosis, just the diagnosis is useless. It's the understanding which can be so useful and therapeutic to the young person and the parents. So that's why I tell parents that look, we don't have to over focus on labels like there's depression or ADHD. Let's make sense of how this contributes to your life, or in a good way or a bad way, and that's where we try and shift. Okay, so it's really interesting points there, guys. If we do you guys want to take a minute, 5 minutes or something, or should we carry on? I might not be able to capture everything, but we can always come back.
We've probably only got another half an hour, Dr. May, so it's probably up to you if you're happy to carry on. Oh, Dawn's just put her hand up. Dawn?
Hi, hello there, Dawn Stevens from Berkshire Healthcare. I just, because we're kind of moving in a different direction, I just wanted to kind of bring up the fact that from a practice point of view, I work in the Berkshire Healthcare safeguarding team, just for the, for information for others. Just in terms of kind of crisis management, and I'd be interested if others agree, what I think it would be useful to talk about is often in my experience, particularly in supervision, practitioners, they appreciate that, there's terrible things often happening at home for these young people, and, they might have had lots of traumatic incidents in their lives. But I think it's something about, for practitioners, the feeling that they're being left holding a risk. And I think everybody's ultimate fear is that something, I'll just name it, that one of these young people will take their own lives, and practitioners might in some way feel responsible. I don't know if that's me making an assumption or if that is really people's genuine fears that I just wanted to kind of get out there in terms of roles and responsibilities and thinking about risk and how that can be managed.
Yeah. Dawn, I'm sure other people will contribute, but I think that's an extremely important point. This is the language we want to move away from, is that there's a clinician who's holding the risk, or a colleague in social care who feels like they're holding the risk. If we feel that we're holding the risk, then that automatically will breed this fear that if this child does something, then we were the ones who were responsible. We were responsible. We were the risk managers, and in some way we have failed. So that creates fear in clinicians, in my opinion. I can say that because I feel fear. I feel fear, I felt fear. And what happens is, with clinicians as well as with, I'm sure, with colleagues in social care, is that we make clinical decisions which are based on or influenced by fear, as opposed to making clinical decisions which are clinically in the best interests of this child or young person. A very simple example, we might have a young person who might be threatening suicide. Clinically, the clinician might be very clear that psychiatric admission is not a good idea, it might be counterproductive and harmful. The child is saying, I'm going to kill myself. So that clinician at that point will find it very, very hard to sort of say, okay, you have to be discharged, you have to go back in the community, and we'll see you. We need to manage you in the community. It's something which is very hard, and the individual factors within clinicians will play a role. What is our personality like? Are we positives? Are we skeptics? Are we a little bit on the anxious side? Are we on the positive risk taker side? So our all individual styles, attitudes, leadership styles, and everything will play a role in that. So I think it is a fact. I repeatedly tell parents that any decision, it should not be made because there is fear of something adverse untoward or death or a completed suicide within the clinician's mind. I take responsibility for telling the parents that because I'm the consultant for the service, most of the time it's actually gone down pretty well. Not in all occasions, but the principle that we have is that if we make decisions based on this fear in our mind that we're holding the risk that what if the child kills themselves, we will repeatedly make the wrong clinical decisions and we're going to harm the child. So that's a belief that I have. There's no doubt about that. But that's the principle that we try and follow in the rapid response team. But yeah, and that's where the shift in language is that let's not think about who's holding the risk. Let's think about exactly what are the needs and what are we doing about it. We just keep saying that. What are the things that are not going right? What is missing? What are the gaps? Let's identify that. Let's meet because all we can do is do what we can. We can't do things which are impossible. So we can just do, if we focus on what we can do and do that, I think that's a better approach than thinking about, I've got to keep the child safe. I tell families, and I tell in multi-urgency meetings, safety is not guaranteed. Nobody's safety can be guaranteed. That is not a realistic goal that I'm going to keep, that the child is going to be safe. So that is not a goal. That is not a realistic goal. I tell parents the same thing. That is not a goal that my child is going to be safe. Unfortunately, that is a tough truth, but that is the truth. We can aim for the child being safe enough. That's a better thing to say. Or the child can be safer. That's a better thing to say. But this idea that we keep perpetuating these fears by using the language that we use, by saying that we're going to keep a child safe, that I need guaranteed safety and things like that. And these are not realistic things. We're not aiming to do that. As clinicians, as CAM services, I don't think anyone will say that by this intervention, we're going to guarantee that the child is going to be safe. By that intervention, we have managed the risk. If you look, we haven't had time to go into the evidence-based literature on suicide, self-harm, and risk. I've got slides there, but none of those interventions actually do anything to reduce the risk. So we do what we can. We meet the needs, and risk is part of the needs.
Thank you, Dawn. That was a really interesting question. There's another question in the chat, Dr. Mehdi, sorry, from Kate Murphy.
Yeah, absolutely. So because identifying the needs, it could take a few weeks, so whilst that process is taking place, we try and relationally hold the young person and the family, not the risk. We hold the young people in a relationship by showing that sincerity, that commitment, that detail, that thoroughness. We need to figure out what's going on with you. And that holds the young people and families. And we also give this list of strategies. That's such an easy thing to do from our perspective, Katie, that we've got a document. It's a self-harm and a distraction. We've created a booklet with the input of service users, actually, over the last couple of years through focus groups. And the service users have actually looked at that document and made suggestions. So we've got this document which acknowledges these challenges, that it's going to take time to figure out what's going on and start bringing ourselves towards better mental well-being. But for the time being, these are the things that you can do. You know, from routine, from structure to physical exercise to distraction strategies to socializing, you know, and then specific strategies for when one is in distress. So we give that actually, and there is a role for that, because you know that's something that, you know, that's all that we can do, because they're at home most of the time with their parents. So you know, at least they have something. Okay, so we feel okay to move on, Esther? So the next bit, would this use one of the practitioners to use the foreseeing counts? Yes. Nikki, there's a document which is available for the public. It's called Coping with Self-Harm. That was created by Oxford, actually, Oxford University, and that was given out towards school. It went out to all the schools, even private schools, and so essentially it's for the public, really, and it's very well written and everything. If you want, I can attach it to this, so you guys can have access to it. But maybe if you just maybe if I can perhaps email that to Esther later on, email Esther, if you're happy to just forward it to the group, that might be okay.
Yes, thank you, Dr. Mundy. That'd be really helpful, and we'll pop it on our website as well, where we've got a new emotional wellbeing and mental health page. So it'd be really helpful to make sure it's on there as well, if it isn't already.
Right. So guys, so you know, in my opinion, these are tricky issues. You know, this concept of holding the risk. You know, we need to keep a child safe. We need to manage the risk. We need to reduce the risk. I always think these are trickier issues. The conversations that we have to have with families, they are tricky. They're not easy. So I try and focus on those really challenging issues in these presentations. And I made it my business to actually look at what is the world thinking about this. By the world, I mean like what are all these specialists in child mental health services? What are they thinking about when it comes to risk assessments? When it comes to doing stuff for children and young people, you know, what is the best approach? So I wanted to share a bit of guidance from various sources around the assessment of suicide risk. So if you look at this slide, this is a couple of specialists in the university in America who kind of offered an opinion. So we start with an opinion, which is quite an interesting thing here to say. Because completed suicide occurs so infrequently, a clinician would actually be correct much more often if he or she predicted that a patient would not commit suicide, regardless of clinical presentation. They say that the clinician's task is not to predict suicide, but rather to recognize when a patient has entered a heightened state of risk. Okay. They also say that predicting low base rate phenomena and suicide with reliability is not possible. I asked GPs if they believe that we, as CAMS professionals, do we do suicide risk assessment, because the suicide risk assessment is giving a bit of a threshold, a grading, where a person is likely, not likely to commit suicide after an assessment. And in this page, predicting that low base rate phenomena such as suicide with reliability is just ruled out. It's not possible. But let's see what other people say. So this is us, NHS. This is Health Education England. This is the Self-Harm and Suicide Prevention Competence Framework, specifically for children and young people. It's also available online. It's an excellent document. And what do they say? So they say that the risk should be assessed, but our ability to accurately predict risk is limited. It is possible to both overestimate and underestimate the actual risk of suicide in a child or a young person at any given moment in time. And the research suggests that we should move away from prediction to focusing on the needs in the person and seeing assessment as informing management rather than a standalone activity. So that's what we're doing. We're focusing on the needs. but this theme is just I think it's just gonna get worse. This page is just highlighting the problems or some of the negative things with risk assessments, because it's often thought that you've done something to protect yourself, that that's a task, that's just one of the checklist approach towards an assessment that you've done. But what is it actually doing? Is that actually doing anything beneficial to the young person or the parents? And it might deter away from doing meaningful holistic assessments. So those are exactly my concerns. We've had these concerns for a while. And what else did we get? So we had the Royal College of Psychiatrists who in 2010 published a report after a piece of work with the Working Party. And what did they say? So there's an overemphasis on risk assessment. There's this issue about holding the risk, and this must be a fear of blame if something goes wrong. And then there is this idea that if you do risk assessments, that we actually are reliably predicting future events, but that's a fallacious assumption. And risk assessments play very little role in accurate predictions of risk. Okay, but more specifically, what I found really interesting in this piece of work was that the prediction of suicide and the assessment of suicide risk in respect of any individual patient is virtually impossible. So do you know that? Oh, I can hear my own. But do you know that there's a common assumption that mental health practitioners, in their assessments for children as well as adults, that we are assessing the risk of suicide. That's an assessment. Apparently we are doing it, but that's just not possible, because the complete suicide is such a rare outcome that cannot be predicted reliably. That common sense tells us, but that's been repeatedly highlighted by various people who've looked into this in much more detail. Okay. So this is nice guidance. Again, it's just saying that an episode of self-harm should be followed by a comprehensive assessment. It's called a biopsychosocial assessment, so that looks at development, looks at mental well-being, looks at social issues. That's what it's asking us to do. And it says that the risk and needs assessments should be closely tethered. Excellent. This makes sense. That's what we're trying to do in our team. And they say that there should be less attention to risk assessment and greater attention given to ensuring a full needs assessment. Okay, so this is some literature just pointing out that the reliability of risk assessments is actually poor. They're not, the risk scales, they don't have good predictive value. There was another paper in the BNJ which looked at this stratification. So if you go onto Rio, one of you is using Rio, you'll see there's a risk assessment document, and then they ask us to stratify it, low, medium, high. And even in our organization, I think there is a risk of self-harm and suicide. So there is this claim that we are assessing risk of suicide. But firstly, common sense tells us that it will be impossible to predict something that happens so rarely. And the outcome of something in the population is so low in its frequency that to assess someone and to sort of say the risk of suicide or what, it's very unlikely. But there is this expectation that we apparently are assessing risk of suicide. So these are very difficult things. To make sense of these things is very difficult. So in this particular paper, they're also highlighting some very useful and specific points. And this last statement: the low positive predictive value of risk stratification means that most people who receive a treatment because of their high risk status will never die by suicide. And the limited sensitivity means that some low-risk patients who will die by suicide might be deprived of treatment options. So so they basically, again, their essential kind of thoughts are focus on the needs and responding to the needs and manage the needs, and that is the way forward, and that is the right way. And fortunately, that's been consistently encouraged by Health Education England, by NICE, by the Royal College of Psychiatrists. So obviously, the move is towards needs, and it's difficult in a frontline day-to-day situation, but we are trying to encourage the right direction, the right philosophy of how we approach these things. Okay, so yeah, there's a battle between risk assessment, safety, that type of language, who's holding the risk, what are we doing to reduce risk. I really try and not even use the word risk in any of my interactions at all. My focus is on needs and what are we doing to make things better with the young person and our colleagues, basically. The approach is always multi-agency. That seems to be the most effective way of dealing with children and young people, because education and development and the family network is key, are key resources that help the child towards recovery. And as I mentioned, what our gut feeling tells us as clinicians, but also when people have looked into this phenomena of what is a suicide risk question now, what is the suicide risk, doctor or nurse? It's not, you can't do that. It's just not doable. So the truthful answer is, if somebody said, what is the risk of suicide? So there's no way, you can't do that. There's no way of assessing risk of suicide. That's the truthful answer. But the answer has to be changed in the middle, of a room full of multi-agency meeting, or if you're with parents, because this might be very odd, very difficult, very strange, if that is the answer that is given. Okay, so this is a bit of advice that we gave GPs on what they can do. I think Yvonne, thank you so much. I think you've added the coping with self-harm leaflet. Thank you so much. But that's something that families can be given. We've created a specific one for BHFT, which starts with a letter of acknowledgement as to that these things are very serious, very important, and we need to take it seriously and work together and try and make more sense, etc. And then it follows by with some of the advice and strategies. So we give that out to our families. Okay. I think if I start the next bit, guys, which is these next sort of 5 bullet points, that will take us to another hour maybe, and we go through how is crisis defined. It's not defined. There's no standard definition. It's a societal discourse rather than a definition. But there's a lot of similarities in it. And then we go towards epidemiology. And what are the rates of sort of self-harm in the population. And then we also got comorbid problems and what works for self-harm specifically. And then there's slides on suicide. So I'm just thinking, I just want to take a second again, and I just want to check if I don't think I'll have time to go through all these slides. I can come back for a shorter part 2 if it helps. But I would suggest we use this time now for just thoughts, discussion, reflection.
I think that's probably really helpful, Dr. Mehdi. The session's only booked through till midday, so we've probably only got another 15 minutes really if people want to use that to ask questions, or if there's any sort of final thoughts you want to pass on to the group, that'd be really helpful. Laura's got her hand up.
Hello, my name's Laura Green. I'm an Education Welfare Officer from Wokingham Borough Council. Now, I do appreciate, Dr. Mehdi, it's not your department, but just going on your case study for Sarah, and I love your wording. You quite rightly, we need to look at the unmet needs, but obviously to look at the unmet needs, there needs to be an assessment. And obviously in Sarah's case, it came down to possibly ASD, ADHD, and obviously in my caseload, I have quite a lot of students with those tendencies that are waiting for assessment. But if you've got any advice what we can do, because we know that the waiting lists are you know, up to 2 years, what can we do while we're waiting for these assessments of the unmet needs? So, and I do appreciate it's not your team.
Yeah, yeah. So was it Sarah? Laura, sorry.
So yeah, but I was talking about your case study of Sarah.
Yeah, yeah. So Laura, I think you being an educational welfare officer, I think you and your counterparts in various sort of local authorities and in various schools, you're likely to have a large number of people who will be struggling to some degree and will be waiting for these assessments. And what we often find is that often schools are sometimes waiting for those assessments, or often schools are sometimes waiting for a particular diagnosis or label, not all the time, but sometimes. And you know, and there's arguments. We've had these challenges discussed in various forums, and there's arguments about what we hear all the time, that you know, firstly, you don't need an assessment or a diagnosis, particularly if you're a school child and there's signs of neurodiversity, for example. School and teachers and everyone is actually seeing that there are social difficulties. The child is maybe getting very overwhelmed with a lot of noise, it needs to isolate themselves, needs lots of breaks, you know, can't manage dinner halls or playground because there's too much social activity going on, and there's high levels of stress and anxiety. So these would be sort of observable kind of needs that would suggest noise hypersensitivity, social difficulties, sensory integration issues. Now, there's often people who will argue that, well, just respond to that as if there is let's say, a need like social deficits or autism or sensory integration issues, and just apply those educational support interventions in the school, and that will reduce the stress that the child is experiencing in the school setting. School life becomes a bit more manageable, and then the child is actually happier at home, as well as you know, there's less resistance in the end. Now, the response from school that we get is, well, we have tons of kids like that. We have tons of kids like that in the school setting, and if you do that for everybody, we don't have the resources. So there's a resources issue. That how do we actually target the resources into the children? So that's why there's sometimes this wait for, okay, we need the assessment of clarity or diagnosis, and then the parents tell us this all the time, that you know, they need this diagnosis. That's when we're going to get the resources and the support and everything. And I'm thinking, well, if you look at the SEND policy, SEND, and the philosophy of education, you respond to the need. This is ideal. Completely understand this is ideal, because we don't live in an ideal world. Everywhere there's limited resources. We've got limited resources for educational psychology, limited resources for educational support, specialist schools, camp services. You know, resources are the limiting factor. But in the ideal world, you just respond to the need. You don't need to wait for a diagnosis. Just apply whatever support.
Yeah, I think what most schools do, especially like with ASD, you know, if you're applying for that, you take it that it as is and you treat as is already. I think most difficulties, I think schools do, in my experience of my particular schools, they do put all those provisions in place. It's getting the child out of the family home. It's the real difficulty.
Yeah.
But
And,
I appreciate it. Obviously, it's a very
the
particular part of the work, but I just think that's, you know, it's just, and it's the therapies that the children's needs. I mean, you know, we do advocate the Overcoming Your Child's Fears by Kathy Cresswell, you know, and working through that, which is, you know, to obviously desensitize, as you suggest. But it's just, it takes obviously so long just to get therapies. But I know, obviously, of course, it's resources. I do appreciate that.
Yeah, no, and it's such a valid point. What do we do in the situations? And I see, and I'm working with schools all the time. You know, schools are actually they work amazingly, in my opinion, a lot of the time with children, young people, and their families in providing that support. Sometimes, you know, the diagnosis is, you know, it's just a process, and regardless of that, the support measures are already in place. So where the child is sitting, to the extra time, to movement breaks, to wobble toys and educational psychology input, a lot of the support is often already in place even before, and then by the time it's a diagnosis, it's just a process. But there is another unmet need, which is another challenge, which is hard to address, and is associated with the limited resources of getting these assessments done. Because if you imagine an adolescent growing up, formation of identity is a developmental expectation in all these kids, and it's an evolving process that goes through adulthood. But it's a fast process for a 12, 13, 14, 15-year-old. And when some of these young people have these assessments and they are able to place a right understanding of why their different reality when it comes to following conversations or not being able to pay attention or not being able to understand other people is explained by, let's say, a diagnostic assessment by the Berkshire autism pathway, that provides young people one level of understanding as to why their experiences have been different and challenged, and where the stress comes from, where the anxiety comes from. And so, like the diagnosis of autism, yeah, educational support is one outcome, but for young people to have an answer in their mind as to why things are different for them is a big thing. It is, if you imagine a young person growing up with uncertainty, with cluelessness as to why is it just me? Is it just me? Is it just me? Why don't I get this? Why am I sort of getting anxious? Why am I making misinterpretations? You know, why can't I keep friendships? You know, why are groups so stressful for me? So these are the thoughts that they grow up with. You know, if there is autism, for example. But it's the process of acknowledging and validation which an assessment provides from, you know, NHS services or privately, that is meeting a need that of identity formation to some degree, not fully. So that's a big plus of actually having some of these assessments, not necessarily for labeling people, but it's for that understanding.
Yeah, yes, I agree. Yeah.
It's not like, okay, diagnosis, autism, there you go. That might not mean anything to it unless the young person is able to relate their experience to what this difficulty causes. You know, in many young people, it normalizes things. Right? Many people like this have the same challenge. And there's hope for the future because many people with autism really benefit from some of the positive traits of autism, like precision and exactness and need to be organized and anticipatory planning, for example. So, yeah. So, anyways, it's a separate point. Yeah, but really interesting.
Thank you.
Any other thoughts or questions?
Yeah, does anybody else have any other questions for Dr. Mehdi before we start bringing the session to a close?
I do have a question.
Please ask yourself the question.
Not for me, actually, it's for you guys. Stop sharing now.
Yeah, you've stopped sharing now.
So this, I mean, what I would benefit from is feedback, actually, and I wonder if everyone can just fill out a feedback form and write whatever they want to write, because the content of this presentation, I mean, it took me 6 months to a year to sort of prepare it, and I tweak it around for whoever I'm kind of delivering this presentation to. So I want to keep tweaking it around and making it better, removing stuff which might not be relevant, but adding stuff which might be relevant at the time. So some sort of feedback would be really helpful, because it is our role as the RRT to actually offer ourselves for any kind of workshops, trainings, seminars, and things like that. Would that be okay? I'm assuming Esther can speak on behalf of everybody else.
We can certainly send out a feedback form after the session, along with the slides, and ask for people's comments and thoughts on the content and how they found it. Certainly, Dr. Mehdi.
Do you want me to send you a feedback form? Because there's one that
if you've got one, yes, please do send it to me, and we'll send that one out. That'd be great.
And I'd be really grateful if as much feedback we have, the more we can improve this presentation.
Thank you. Does anybody else have anything they'd like to raise at all at this point? Lovely. Okay. Thank you. Well, thank you, Dr. Mehdi, so much for coming along today. It's been really fascinating to hear you speak, and so positive to hear your views on looking at unmet needs rather than just presenting issues and trying to treat those, and actually trying to sort of look underneath at how we can support that child and their family with the underlying causes of the issues. So that's been really, really helpful. Thank you very much.
Thank you very much. It's a pleasure.
It's been great, thank you. I hope everybody's enjoyed today's session. When we send the slides and everything out, please do take a look at our Berkshire West Safeguarding Children Partnership website. There's a huge amount of information on there. And as I mentioned earlier, we've got a new page which is around emotional wellbeing and mental health that colleagues at the CCG have helped us to put together. But if anybody has any additional information that you think would be useful to have on there as a sort of a central resource for people, then please let us know. Otherwise, thank you very much for coming. We will put the link in the chat, Nicola, through to the BWSCP website, but I think everybody's probably got my email address, so if anybody wants to email me, I probably didn't introduce myself right at the beginning. So I'm the partnership manager for the BWSCP, so please do get in touch with me if you have any other questions that you'd like me to pass on to Dr. Mehdi that you didn't think about during the session today. Thank you very much, and hopefully see you again next time we organise one of these sessions.
Thank you. Bye.
Thank you. Bye-bye.
Thank you.
Thank you.
Thank you.